Uh, hello, welcome everyone. Thank you for joining our Tuesday VMR. I'm very excited to co-discuss with Ravi today, and also super excited for a case that Eugene kind of alluded to us in the group chat. So thank you, Eugene. I look forward to your case. And also, I think Sakas is doing teaching points today, and Lara and Sam are helping with the scribing. So thank you both very much. Maybe before we get started, let's hear a few words from Eugene and then Saket and Sam just to say has maybe a quick update on what you're up to lately.
Yeah, thank you so much, Dr. Mengyu. Yeah, so yeah, this title, The Case of Life, it's a fantastic case that it's sparked a lot of teaching, and I'm happy to be presenting it today. What is going on in my life, I'll just share with Dr. Ravi that I started a ritual of 10,000 steps a day. I did about 4,000 in the hospital, so this evening I'll go along the beach and try to complete the rest before taking my bed. Yeah, so that's that.
Wow, thank you. That's amazing. How about you, Sam?
I'm doing well. I just got back from Minnesota. I was there for a month and doing a rotation in the emergency department. So I'm just settling in back home. And yeah, just doing my residency interviews for emergency medicine and just trying to get through that whole process. But
Yeah, well, good luck. That's
yeah,
definitely exciting time.
yeah.
Um, and Saket, you want to say hi?
Hey everyone, I'm Saket. I'm Nanji from India. And yeah, Eugene's cases are always very intriguing and I looking forward to it. Excited for the discussion.
Yeah, and Lara, I don't know if you're able to unmute.
Yeah, absolutely. Hi, everyone. Doing good. Very excited for the session and for another amazing case from Eugene.
Yeah, awesome. Maybe we can get the whiteboard started. In the meantime, Ravi, I know you wonder if you have updates for us, and I know you're probably very busy
Oh,
with interview season nowadays.
oh yeah, absolutely. Yeah, I was just mentioning to Eugene, I'm sort of cognitively depleted from interviews this morning, but very excited to discuss with you. And if you've never hung out with Mengyu, I recommend everybody to. She's amazing. She's just a lot of fun. And I met her at a meeting. It was this year, right? Yeah, I think it was April this year, Louisiana, New Orleans, and we had fun hanging out together. We also met Gurpreet Dhaliwal, so that was a great time.
Yeah, it was a great time hanging out with you, Ravi. Hope to see you again every year. But yeah, looks like we have the whiteboard up, so why don't we get started? Look forward to your
Yeah,
case, Eugene.
yeah, thank you so much. I'll start with the first aliquot, which is the chief complaint. So it's a 12-year-old boy who was brought to the clinic by his parents with multiple joint pains and lower back pain, ongoing for about a year. I'll pause there and then play a text.
Oh wow, first a 12-year-old boy. I have to activate some of my uh, pediatric or modes of those are in a sleep. But I think maybe I'll start with what I know, which is the multiple joint pain, which I translate to polyarticular process, uh, and the additional lower back pain. It's because I think there are a little bit of a little bit tension here because when I hear multiple joints, when I think about polyarticular um, arthropathies, I would think of mostly involving small joints, but lower back pain, which usually is grouped with the large joints or oligoarthritis kind of a spectrum of diseases. Um, and I think we've discussed in the past where of course, when you hear about joint pain, you can think about the extra joint structures, but the more joints is involved, the more you actually think is a intra-articular process. And if we name the problem as a polyarticular arthritis. I think first we have to clarify if there's an inflammation going on. Ask for all the features of inflammation, like fevers or like weight loss, like elevated inflammatory markers are some of the clues. And also on exam, if there's any joint swelling, limited range of motion, like looking for clues for inflammation. But if you're thinking about if you're in that space, you think about most common being, if we ignore the tempo, then you think about viral and autoimmune being the two most common. But then we hear the fact that it's been there for a year. I think that immediately make the viral etiology very unlikely. So the question is, are we dealing with an autoimmune process? I think that's like where my mind lands right now. Also, if you layer on the back pain, maybe I'll ask Ravi to see if that adds anything and if you have any additional thoughts of this. Especially
Absolutely,
with,
yeah, absolutely, Mengyu. Yes, interesting. You started off thinking about all the different areas of joint pain, and then conditions that can actually assault the joint, such as inflammation or non-inflammatory conditions. So I would add to that arthralgias as well. So is there joint involvement without joint destruction? Because inflammation, because there's a cellular assault on the bone itself or the cartilage or the different tissues, there can be also destruction of the joint as well. So imaging will be crucial here. And I think lab work will also be very crucial to differentiate if there is inflammation versus non-inflammation. There is the old sort of adage of, if your pain is less than 30 minutes in the morning, and not in a younger person, but in an older person, you would say in internal medicine, you would say pain less than 30 minutes probably is non-inflammatory. Pain greater than 30 minutes is probably inflammatory. So that's usually what the textbooks would say, but I've never really met somebody where 30 minutes is the clear distinguishing time frame for pain that could be due to or scripted due to or ascribed due to inflammation or non-inflammation. But I think the joints plus the back, if I employ or deploy system on thinking, ankylosing spondylitis, but again, a younger person, you start thinking about what kind of distribution of inflammation through the anatomy of the body you can have, and that's the big one. And it's sort of an umbrella term where there are many other features ascribed to that. So I think getting more associated features, like you said, is there fever associated with this? Is there something we're dealing with a 12-year-old boy? So could there be something congenital? I don't think Eugene is going to give us a pediatric, although the patient is 12 years old, but we're going to have a condition that likely is also seen in adult medicine as well. So I think key features to sort of think about: arthralgia, non-inflammatory arthritis, inflammatory arthritis. And then when there is pain in the joint areas itself, do you want to determine if the pain is actually coming from, is it actually coming from the joint? Is it coming from the nerve? Is it coming from other surrounding structures? There's muscle, there's ligament, there's tendon, there's bone. So any one of those. So maneuvering the joint and palpating, doing the physical exam will also be very crucial in this case, right? Is there actually edema there, or is there any pathology surrounding that area as well? So it's going on for quite a while. So I'm kind of suspicious of something inflammatory, but let's see what other data Eugene has for us. Any other thoughts, Mengyu, before we turn the mic back to Eugene?
Oh, just a quick, I realized I jumped into polyarticular process, but I think we didn't know specifically what multiple joint means here, like what joints and how many. So I think Eugene will tell us more to help us make sure we're solving the right problem.
Yeah, thank you so much for that discussion. And then I can see the chat is also so much on fire. So I'll give us some background data, additional just so he was a very healthy boy, according to his parents, until around his 11th birthday, when he began having pains in his wrists and in ankles. Mostly they would be very severe at night and then they would be fine. But over the time, those wrist and ankle pains got a bit mild, and then he began complaining of his wrist pain. That became more persistent and the most troubling symptom. His parents have taken him to multiple different hospitals where it was mostly attributed to growing pains. And then according to them, nothing remarkable was found on tests aside mild anemia, and he was put on some iron supplements. He was also given analgesics most of the time and sometimes antibiotics. We also tried herbal remedies, over-the-counter painkillers, which gave him temporary relief. Apparently, his wrist and ankle pains are mild, but the wrist pain became very severe. It was 10 out of 10 on the pain scale. And that was the evening before the admission, and he could even barely sit upright or walk. With ROS, notably in the past 5 months, he has lost some weight. His appetite has been poor, and he has become less active, sometimes missing school. He often feels warm, he's occasionally dull, he has abdominal pain, and a cough that is sometimes productive of flare-wise sputum. He has had no persistent skin rashes, no chills, no night sweats, no vision changes, no chest pain, no shortness of breath, no gastrointestinal symptoms apart from abdominal pain, no dysuria or cooler-colored urine, and no recent travel history. For past medical history, aside upper respiratory infections, there have been no chronic illnesses, no hemotransfusions. He's had multiple sickling tests done. The parents said sometimes it was positive, sometimes it was negative, so there were these conflicting results in the various hospitals they went. And then I just have a little pediatric history. It's really unremarkable. He's had normal developmental milestones and up-to-date vaccination schedules. His drug histories are the high on pill, vitamin C tablets, ibuprofen, paracetamol, amoxiclav, IV ketrazolam, and azithromycin. Then the family history is unremarkable. He doesn't have any siblings with similar issues. He's one of 3 children. No known malignancies in the family, autoimmune hematologic disorders. He's also a student and he lives with his family. So I'll pause with this background data. I want to hear your thoughts, your broad differentials, and what would you objectively suspect in the next day?
Absolutely wonderful, wonderfully described, aliquot. So rich in details here. So when we start nitpicking the key features here, I'm very like nervous for this patient, especially with all this multi-systemic sort of associated features, and they alarmingly do kind of spell out there's this inflammation. The weight loss is very concerning. If we just try and sort of break down weight loss, if we think about it, non-inflammatory, inflammatory, and the inflammatory causes on the CPS schema pretty much malignancy, autoimmune, and infection. So here, Mengyu did talk about, could there be infection when you have joint pain? You could have septic arthritis. You want to worry about something very, very sinister. But here, if this was septic arthritis, septic joint, this would immediately decompensate the patient. Infection leads to sepsis, leads to septic shock, and I don't think it would play out over the course of a year. So this way we have to switch to possible malignancy or possible autoimmune disease here. But autoimmune disease here is screamingly loud at this point because certain features. So a couple of features, I would say the weight loss, the reduced appetite could also be due to malignancy, but usually malignancy with joints of this distribution is very unusual. If you have metastasis, 2 joints, it wouldn't be, could be the spine, but I wouldn't think it would involve small joints in this manner. And then feeling warm could indicate a fever. So even low-grade fever could be prescribed due to autoimmune phenomena. And then abdominal pain and cough. I'm kind of having difficulty trying to prescribe these 2 joint inflammation or a multisystemic autoimmune phenomena, but you could have non-specific features, abdominal pain. Are there any histologic, any connective tissue, any histopathological association with bone and cartilage and intestine, linings, fascia, muscle? Really not, unless we talked about muscle around joints and muscle in the abdominal area. Cough itself is probably the only thing I can think of, like lung association plus joint autoimmune phenomena. So you can get ILD with polymyositis, dermatomyositis, certain malignancies too. But here again, we're dealing with 12-year-old boys. So, but again, I'm not going to sort of go off track and just go into the world of pediatrics. I'm sure there's going to be a case of adult medicine pathology in a young person. Anything else, Mengyu, that comes to mind?
Yeah, agree. Yeah, what an interesting case. And I'll see why it's named like after 11 because the onset is after 11 years old. And I definitely agree. There's definitely a lot of inflammation going on. And I think, yeah, as you said, if it were a infection, I think the only infection we could think of is some sort of chronic infection. Even that, I feel like it seems to drag a little bit long, but I think we could consider. But I think what really makes me think it's less like a fit less well is usually infection like chronic infections like granulomatous infections or those like lives in the intracellular space, like they tend to cause more of a oligoarticular picture, like involving some of the larger joints. Although I've learned before in this space that the more intracellular the organism is, the more joints it tends to involve. So I think we can consider some of the indolent infections being a possibility here. But so we could explore those like risk factors or any other clues like outside the joints to suggest a systemic involvement. You know, whether we're thinking infections or autoimmune, I think looking for clues outside the joints will help us make progress. But overall, I think the picture fits well. I agree with Ravi in that fits mostly well with an autoimmune process. I think in the young age, I would think of juvenile idiopathic arthritis. I don't see a lot of those cases because I don't see pediatric patients, but I think those are on the differential. I think if this happens in an adult, I would think about rheumatoid arthritis, sometimes like psoriatic arthritis, you know, like those, or IBD associated, like in the that can associate with both spondyloarthritis, back pain, but also tends to involve small joints. So like RA, psoriatic, and lupus is also can cause similar picture. If it or in an adult, in a young patient, I think lupus is still possible. I think RA very unlikely, but we can replace that with JIA, and really look for extra articular clues, because one specific type of JIA you could have like Still's disease kind of, but you would expect abnormality in the white count and other organomegalies and serositis and things like that, and more remarkable fever, I would say, which I don't know if that's the case here yet. Yeah, so I think we'll look for those clues and also keep infections in the back of our mind. Cancer, I can think of something. I feel like lymphomas can mimic a lot of the things, but I think leukemia is something you could definitely look for if there's signs on CBC. But I feel like we usually expect the more acute course, but I'll keep my mind open at this time. Yeah.
Yeah,
Anything else?
Mengyu, yeah, that's very interesting. I was just going to springboard off what you said. You said a lot of great things. And also, I think, yeah, the rheumatoid arthritis is interesting. And you then thought about abdominal pain. And immediately I kind of system one thinking, Felty syndrome, Iron in the chat. Hopefully I pronounced your name correctly. And he mentioned, could there be spleen-related abdominal pain? Felty syndrome, you get rheumatoid arthritis, neutropenia, and splenomegaly. So that kind of could fit the picture, but I'm not going to sort of shoehorn this diagnosis in, but it's just kind of fun to just say Felty syndrome because we don't really usually see that much, or we just kind of learn it for step one and then kind of forget it. But I think this wrist, going back, this wrist pain, in certain cases we've had on CPS, wrist pain could be indicated by CPBD, has a predilection, osteoarthritis. In certain cases, amyloidosis and carpal tunnel syndrome and acromegaly, certain conditions, you can get this wrist pain, but could it be a signal or feature of a systemic condition, or it could be due to one of these conditions? I'm not sure, but it'd be kind of interesting to see how the labs and see if there's neutropenia. The anemia, I think Lucas had mentioned, could this be due to anemia of chronic inflammation? I think it could. If there is an autoimmune phenomenon on board, likely there is going to be anemia of chronic inflammation. Back to you, Eugene.
Yeah, thank you so much. So this semester part would be the examination findings, and then I think it's can bring more light about some of the questions that we asked. So for vitals, heart rate was 101, respiratory rate was 20, SpO2 was 99% of room air, temperature was 38.1, was fever, BP was 10268, his RBS was 101 millimeters per deciliters. Generally, he was chronically ill looking, he was pale, febrile, but anecteric, and there were no reddening of the eyes. He was fairly hydrated, and we didn't see any skin lesions on general exams. The extremities had no pedal edema, there were also no lesions on the extremities. Lymph nodes were palpable, there were multiple palpable cervical and right axillary nodes. They were discrete, they were thin, they were non-tender. Then musculoskeletal, aside the wrist, which showed some mild pain, they were not stiff, but we saw a tender paraspinal swelling alongside the lumbar spine. And then chest was vesicular breath sounds, but with mild rhonchi at the mid and lower lung zones. Cardiac exams, S1 and S2 were normal, no friction labs or murmurs. The abdomen was flat. There was a mild right hypochondriac tenderness. Spleen was just palpable, just 1 cm below the costal margin. The liver was not palpable. CNS was intact, GCS was 15-15. So I'll pause here and then allow you to share your thoughts and whichever labs that you anticipate with the remaining of the program.
Oh wow, what an interesting case. I think as Ravi, you kind of predicted there's some splenomegaly and also those could explain the abdominal pain. And so yeah, I think looks like, to summarize, we have a boy, a teenage boy presenting with a chronic inflammatory syndrome featured by polyarthritis, um, and reticuloendothelial system, activation with lymph nodes and hepatosplenomegaly, and even some lower, lumbar spine involvement potentially here. So I think so. First, with the I think the feature, and I think we're still looking for any additional clues in the lungs given the symptom of cough. I think infection and autoimmune are still on the differential pretty strongly here. Especially among the autoimmune processes, I think again, GIA/Still's disease is possible with the lymphadenopathy, hepatosplenomegaly, and the fever. And I think we'll look for labs for additional clues. And the only thing I'm missing is like we don't see any rash, and we'll see if there's any serositis on later imagings. And lupus as well can cause lymphadenopathy, and I think hepatosplenomegaly is still possible. And then speaking of those are the two autoimmune diseases that are in my mind. I think along the same lines, some infiltrative diseases, like HLH, which is along the line of like Still's disease almost, because they have like very similar. They often on the spectrum. If HLH happens in the setting of autoimmune disease, it's basically called mass, as macrophage activating syndrome. And it's likely secondary if that's the case. And then I think infection wise, you think about a bone, a disease. So think we already talked about, and when you think about infections, think about the more chronic, like granulomatous infections. They tend to then infiltrate into the reticular endothelial system and also involving the bone. So I think you could think about the type of infections, and because the granulomatous infect tend to involve the bone for many of them. So I think those are still on the table. So question is how we can more definitively rule out or rule in an infection before we consider more of autoimmune kind of pathway of treatment. So I wonder if, so I think sending some serologies would be helpful, and maybe getting if the wrist fluid is enough for it to be drained, then we could potentially get fluid there as well. Or if additional imaging suggests other, like serositis or other sites, or even a lymph node biopsy, I think might provide clue. But we'll see what other data we have first. But curious what you think, Ravi.
Oh wow, Mingy, you just explored the vast landscape of possibilities. I only have a few things to add, and one is the granulomatous infections. I think TB can mimic so many conditions, so that's definitely in the running. One test definitely I would have to do is an HIV. I guess acute retroviral syndrome can have, it's like a flu-like illness, not of this duration though, but I think we would have to do it just in case. What if there's a AIDS, and there could be an opportunistic AIDS-defining infection, and again TB is right in AIDS as well, and there's this recurrent respiratory infection. So just that itself to me spells out this patient's been having recurrent infection. So what kind of sinopulmonary infections, respiratory infections can you have? You can have a immunocompromised condition, IgA deficiency, CVID, and certain conditions where you have a predisposition to recurrent infections. Recurrent sinopulmonary association, could this also be, if we think about granulomatous conditions, could this be vasculitis? I will nudge this in to the conversation. I'm not sure of this. I would just kind of mention it. But again, we're thinking about this recurrent infections, especially associated with the lower respiratory tract infection. Leukemia at this age. Well, if we question like what kind of leukemias would affect a 12-year-old male, more likely if you follow the trend, it's not always clear, but ALL at this age is usually associated up till teens, 20, around there. Then comes CML, AML, and CLL is at the extremes of age greater than 70 and beyond. So ALL, acute lymphoblastic leukemia, it can actually manifest in this manner, and there is an association, I think, with Burkitt's lymphoma as well, and EBV. Somebody mentioned EBV, so that would be something to think about in this condition. So we mentioned TB, lymphoma. Could there be leukemia in this case as well? The spleen is involved, and what other infections that Eugene could see in his neck of the woods? Malaria. But again, I think this patient would have presented much earlier. There would be splenomegaly in this case as well. The bones, I mean, could be affected in this case. You just feel terrible. So I would kind of think about it, because initially I kind of wrote off infection. How could you have an infection for this long without really decompensating? The temperature is pretty high up there, so it makes a valid argument for fever at this point. But those are a few thoughts I had at this point, and I definitely would be interested in some laboratory data. Any other thoughts, Mengyu, before we send the mic back to Eugene?
Yeah, I just have one additional thought because I love your catch on the recurrent respiratory infections, which I almost overlooked. And because one thing that came to mind was, could this be an immunodeficiency that often have very similar features, in that like although CVID happens mostly in the like 30 to 40 years age, so it doesn't fit the age, but could there be some like A-gamma globulinemia? Although you would think that would happen even younger, but there are some variations to like in the spectrum of immunodeficiency that could present a little bit later age. But then you could have, because of chronic stimuli, antigen stimuli in your body's immune system and reticuloendothelium, you could have chronic like lymphadenopathy or hepatosplenomegaly. Although and also note the caveat that if the patient does have some A-gamma globulinemia kind of picture, your antibody test wouldn't be helpful because they would always be negative. So I think checking the immunoglobulins would be helpful to make sure that's not at play here. Although overall, I feel like the course is more fits like I'll just keep that on the differential, but don't see it as a classic picture of that.
Maggie, that's a very interesting. While you were talking, it's interesting when we do this co-discussion. While you were talking, it immediately set off a chain of thoughts in my mind. A-gamma globulinemia, nothing is being produced to fight infection, or you have hyper inflammatory or hypersecretory conditions, right? So like paraproteinemias, where you make a lot of immunoglobulins, but they're not functioning, so you can have recurrent, you have an immunocompromised condition because the antibodies that are being produced aren't working, so they don't protect you against infection. So I think you have this nice dichotomy here of either underproducing or producing too many, which are dysfunctional. Maybe that's something that's going on. So some paraproteinemias can manifest with like in a pseudo malignancy kind of pattern as well. They can form masses in various tissues as well. But let's send the back mic to Eugene to get some data.
Yeah, amazing. Thank you. So I'll give you the labs. So for complete blood counts, HB, yeah, they brought in a baseline CBC, and then we did that was in the hospital. So the previous was 9.2, but when we checked, it was decreased to 8.8. MCD previous was 70, decreased to 63. MCH previous was 22, decreased to 19.5. WBC's previous was 28.8, but it had dropped to 25. The predominant cells in our labs, neutrophils was 16.6, was raised. Monocytes was also slightly raised at 1.10, and eosinophils was also markedly raised at 4.2. Then platelets had increased from 487 to 582. The reactive count was 0.4%. We checked some inflammatory markers. ESR was elevated at 105. CRP was also elevated at 26. Then the viral screens that you asked for, HIV was negative, Hep B was negative, hepatitis C was negative, EBV was negative. Then, yeah, let me pause here. If you have any extra labs, you can ask them, then I can provide them.
So it's my turn to take a stab at this. So the SED rate really stands out to me. It's non-specific, but when it's elevated above 100, there's a cry for help. There's major inflammation that's in process here. Certain times the ESR in questions, I love to do board review, and usually this is associated with vignettes for temporal arteritis, right? So age over 50, ESR greater than 100. This is probably a cause or case of vasculitis, large vessel vasculitis. But here, ESR could be prescribed to like any sort of inflammatory condition within the body. So it could be vasculitis, it could be bone associated, it could be soft tissue associated, so enthesitis and so on, connective tissue disease. So here, the CRP is also elevated, not proportionally, but there's nothing that you can really put a pin in that is associated with this with these levels here. So, but it's just pointing to inflammation. Again, inflammation / infection. The hemoglobin being low, we had hypothesized earlier on that there's probably anemia, and MCV being very low. So I usually deploy a mnemonic TAILS, which will be thalassemia, T for thalassemia, A, anemia of chronic inflammation, I, iron deficiency, L, lead, and S, sideroblastic anemia. So here, most likely is going to be iron deficiency / you could have actually a dimorphic anemia. You may have iron deficiency plus anemia of chronic inflammation. So I think the next test would be a ferritin, but you're going to say, we're like, wait, ferritin is going to be, off the rails. It's probably going to be high because there's a lot of inflammation. So you go to the next most probably helpful test, which is either going to be a % iron saturation. If it's less than 20, or you'll be like, maybe there is iron deficiency, but if it's less than 10, you pretty much have a slam dunk iron deficiency anemia. And if the ferritin is high, iron deficiency anemia plus anemia of chronic inflammation. There is also this other test, which I've never been able to hunt down, the soluble transferrin receptor test. I don't remember the rest of it. So I asked this question of somebody doing a grand rounds, and this test isn't readily available, but it's not influenced by inflammation. So it will be very helpful to try and discriminate iron deficiency anemia in the presence of inflammation here. So again, the white cell, okay, the white cell is high. Now I see it. So 28,000. So that's extremely high. What would be the causes for leukocytosis in this case? Yeah, definitely infection. Where's the infection? At this point, lymph nodes, getting biopsy of the lymph nodes might be very helpful. And to this degree, if you look at WBC counts greater than 20,000 or 25,000, 30,000, leukemias comes into consideration. So that's something we may have to think about. But first order of business is to rule out an infection. If there's no infection, then leukemias, medication-related, stress, pain wouldn't increase white count to this degree. Necrosis, autoimmune disease, necrosis of tissue, like gangrene, like Fournier's gangrene, like Ludwig's angina, things of that nature, like necrotizing fasciitis would give you super high white counts like this. But I would also think about, I think that would be my list of differentials for a white count of this degree, with infection being the priority here, and then looking at all the other causes. Neutrophil predominance may be a pyogenic bacteria/bacteremia in this case. Anything else, Mengyu? I'm kind of thinking over these
Yeah,
data points.
I love your discussion. I was also really caught attention by the super high WBC. In the acute setting, like when you see this high WBC, you think about C. diff or pertussis or abscess with like a pus under pressure kind of picture. But we're more dealing, I think those could be considered, but we're more, sounds like dealing with a chronic process. So we have to explain all the other syndromes that are likely to be part of it. So I think one thing that still lingers in my mind is the theory of like a Still's disease, which is often can cause really high white count and inflammatory process. And with everything, the hepatocellular, everything still fits that picture of a JIA related Still's kind of disease picture. I think leukemia is an important consideration that can be assessed with a blood smear, looking for blasts. And of course, do all the diligence with the workup in terms of ruling out infections. Still, as mentioned earlier, I would say SLE is less likely because of the degree of, usually it causes leukopenia and thrombocytopenia. So that's less likely to play here. Unless it's like complicated by MAS, I guess maybe that would be a little different. But I'm wondering also for the next step, I think we can do the HLH workup with other than exhausting the infectious workup and the leukemia workup, but also send, like, as you mentioned, soluble IL-2 and triglyceride, fibrinogen, ferritin, of course. If it's super high, then it's like thousands, and that's also very suggestive, helpful.
Yeah, Mengyu, with this adult ancestral disease, that's a very interesting diagnosis to entertain here. I do appreciate you bringing that up. I didn't really think about it, but again, I think what's really throwing me off, the bias I have here is this is a 12-year-old boy, so I'm not used to seeing conditions like this, and especially AOSD in such a young patient. I think what would we do here? I mean, the ferritin will be, if you do a random ferritin, it will be really high in AOSD. Certain conditions, HLH, histoplasmosis, where it can be really elevated in this case, but AOSD is one of them as well. The one thing that bugs me here, I'm not seeing the criteria, which is described as being Yamaguchi criteria. There's certain features, and one of them is the evanescent salmon-colored rash. I was like waiting for Yuji to say, "Oh, there's this rash," and it goes away and appears with the fever, evanescent rash, and with this what do you call this, undulating fever that you get pattern. We don't have that, but you can never say never. What if he says in the next article, and the patient had a salmon-colored rash, then that really will give away the diagnosis. But I haven't thought about ASD in a while, so this is a great point to just re-educate ourselves about this condition.
Yeah, curious to hear more, Eugene.
Yeah, thank you. So yeah, there was no salmon colored rash. Let me explain out there. It was never seen. And yeah, the autoimmune picture was still on the back here. But we did some labs as you asked for to rule out infections. Let me start with the ferritin. Ferritin was 420. It was mildly elevated, not very exaggerated. Urine R, we had three classes of blood, one class of leukocytes, but no proteinuria. Then we sent urine and blood for cultures. Then the BNP, renal function urea was normal, 15.6, creatinine was 0.58, electrolytes were all normal, sodium 141, potassium 3.8, chloride 103, calcium 9.3, phosphate 3.8. LFTs, the transaminases were all normal, ALP normal, T-bill normal. Albumin was slightly low, that was 3.2. LDH was elevated at 480. We also sent for blood film, just as you requested. We had aneuploidy, the microcytic hypochromic cells, and then target cells were also seen. The white cells were of normal morphology. And we also checked for malarial parasites, and there were no malarial parasites. Then we did the HB electrophoresis. It was of AS genotype. And then we have imaging. I have a chest X-ray here. I'm going to share my screen so that you can see. So kindly let me know if you can see my screen.
Yes, we can see it.
I can start since I guess it's my
Sure.
turn.
Sure.
I think what jumps out to me is really the perihilar fullness, which makes me think about potentially lymphadenopathy. Wanting to make sure there's not like a consolidation there, but I think lymphadenopathy could definitely fit this picture, almost like a potato, almost like what you can see in sarcoidosis. But otherwise, the long parenchyma seems pretty clear, and it's also costophrenic angle is pretty clear. Heart border is size is normal. Don't see any major bone abnormalities, although I'm not expert in that. Airway seems okay too. What do you think, Ravi?
Yeah, I think a lot of the findings they're very rich within the area of the hilum, and it's not the traditional, say, sort of like bilateral hilar lymphadenopathy, like bilateral eggshells or potatoes. I kind of use that example for teaching bilateral hilar lymphadenopathy, but my thought would be the lymph nodes within this vicinity might be causing this picture here. It is a very, what we call a wide mediastinum. So does that mean aortic dissection? Likely no, because the patient's not describing the pain. There's pain within the chest going down, and it's not hyperacute. But yeah, the hilum is of interest in this case. I think this warrants a CT because this is very kind of obscure. I think a more clearer definition of this area will be necessary in getting a transsectional CT will be very helpful to determine what's within this area here. But again, lymph nodes all over the place. We have to start thinking about sort of widespread infections, TB, HIV was negative, and I would start looking at autoimmune phenomena, leukemias, still are in play, lymphomas. I would say maybe transsectional CT and a biopsy of the lymph node will yield a lot of points. Anything else before we turn the mic back to Eugene?
Yeah, no, I think it's very helpful that, although a little disappointing, that the ferritin is normal, so that doesn't put us in the direction of what I was thinking earlier about the Still's, the juvenile onset Still's disease theory. So then wondering, with the pretty remarkable lymphadenopathy correlating with the LDH, I wonder if but also helpful that we don't see any lung parenchyma like a TB process that you would expect. So maybe the cough explained by the whatever's going on in the mediastinum. So I think, yeah, I agree, like CT would be helpful to clarify if it's a lymphadenopathy, making sure there's no thymoma involved, but like if it's a lymphadenopathy or I think lymphoma is on the table still. Uh, trying to think.
I think remember ALL when I talked about
Mm.
the distribution of leukemias amongst age. So ALL being in the younger population, but there is the T cell variant of ALL, I guess T cell associated ALL, can manifest with mediastinal masses, and which we're seeing in this X-ray and causing widespread lymphadenopathy. That will be so. Yeah, we definitely need to pursue the cellular makeup of what's causing this and the white count. Differential shows neutrophilia, but yeah, we definitely need to do further testing. I think we need to go, what do you call it? Sun's law. Go where the gold is, or something like that. Yeah, Willie Sun, the famous bank robber, and Sun's law predicts like you go where the evidence likely is to the diagnosis. So let's turn the mic back to Eugene and see.
Yeah, actually, just realized there's another clue here that the urine is positive for 3+ blood. So I think I have to clarify, maybe repeat the urine and look under microscopy, see if there's a glomerulonephritis involved, in which case I think lupus has to be considered. Because if you think about granulomatous infections, that tends to cause like an interstitial process. But if it's a GN, then taken together with autoimmune, I still have to think about lupus and like just wanted to keep put a pin there. I think also if it's ALL, you would like expect more lymphocyte predominance. But yeah, maybe back to Eugene.
Yeah, amazing. So yeah, we taking a crack at the chest X-ray. We thought there was some mediastinal widening and bilateral highlight lymph nodes, but this the report on the chest X-ray was just bilateral highlight findings, and that was all. At this time, urine CS, blood CS had no goods, and we did advanced imaging. Also, we have started supportive treatment with triazone, chemo, azithromycin, some fluids, and then chest CT. We had multiple bilateral, non-calcified pulmonary nodules. The largest was up to 0.6 centimeters. Then we had bilateral hilar lymphadenopathy, largest was 1.5 centimeters. But then they saw no bulky mediastinal mass. There were no pleural effusions, no osseous lesions, and the cardiac CRS was normal. We did a CT abdomen. The splenomegaly was there, it was about 12.8 cm. There was para-aortic and iliac lymph nodes, which were enlarged. Largest was 1.7 cm. There were no liver lesions, kidneys were normal. And then they saw a lytic lesion in the L2 vertebral body with mild soft tissue extension. So we did an MRI of the spine, L2 vertebral body lesion with marrow signal change, which we said was compatible with marrow infiltration, and also saw paraspinal soft tissue components, no cord compression. There is a last aliquot that reveals the diagnosis. I know we are constrained with time, but I'll pause here to hear your thoughts. Then I will show the last aliquot to you.
Wow.
What do you think, Maggie?
Oh yeah, I think the soft tissue lesion, lytic lesion in the bone, I think probably the next step would involve a biopsy there. And the question is whether it's an infection, which sometimes can mimic like a TB or NTM or fungal, like, that's, or is it a lymphoma, which tends to involve the bone in a young patient, like a Burkitt's lymphoma or something like that. Or yeah, this is where I'm thinking. I feel like a biopsy would be important, assuming some serologies are in the workup as well. And not, I think about like a multiple lung nodules also suggest I think that would make you think of infectious process, because that's where it enters the lung. I think I'm just rambling at this time, so maybe Ravi, you can put in your thoughts, and I'll see if I have additional thoughts.
Yeah, absolutely. I think there was a case a couple of weeks ago that I discussed with Maddie where histiocytosis was non-Langerhans cell histiocytosis caused a similar condition with signal in the spine and lytic lesions and lymph node involvement. So that's something I would think about in this case. However, Langerhans cell histiocytosis can happen in pediatric cases as well. So something to think about. Leukemia is still there. What kind of lymphomas could be occurring in this case? I think you can have a non-Hodgkin lymphoma, which could be associated with this. Solitary plasmacytoma, spine, but usually you just have signal in the spine. You won't have this diffuse, devastating presentation like this. And then you have to think about just paraproteinemias in itself. So multiple myeloma. There was no, I didn't see an SPEP, UPEP. Could there be GN due to that as well? I mean, you can't help but think about carcinoma with the lytic presentation to the bone. You wonder. Non-calcified nodules. I mean, usually calcification, the body is trying to wall off if there is an infection causing these nodules or lymph nodes in this case. My landscape of possibilities are the ones that I just mentioned. I really can't tell you which one is the lead hypothesis at this point. Very interesting, but I think a lymph node biopsy likely, again, I keep mentioning it, is warranted at this point.
Yeah, my mind lands in the long bone schema where the differential would include infections, including granulomatous infections, but also cancer, and in this young age of think about lymphoma, but also, as you said, histiocytic disorders at Chester or Langerhans, but then some storage disorders that I have less robust illness scripts on, like Gaucher. But I'm just trying to figure out how I feel like there should be clues that would help me pin down one of the diagnoses on this list, that I might just be not efficient enough in recognizing.
Yeah, I think that this is a great case. It's it's a very educational case, and I think we'll definitely learn. I think in the chat again, TB. We got to come back to TB. Lucas has mentioned everything is TB, and it could be a possibility. So wonderful presentation, Eugene. I really love so rich, and well presented. Any other thoughts before we send the mic for the final time back to Eugene?
Not right
Hey,
now. Look forward to learning.
Thank you. So yeah, at this point, I think we put two things in play. I mean, we are a low resource setting, and then we decided to follow after where we could have more juice, just like Dr. Ravi was saying, and that was the lymph nodes. We had a CBC that gave us some anemia and then leukocytosis, but we didn't have too much in there to worry us when we did the film comment. We had some ferritin, but not too elevated to worry us with some other disseminated diseases, Castleman's, etc., HLH. Also, the rectal count, which was low, told us already that there was some kind of infiltrative process ongoing in the bone marrow. So we did 2 biopsies so that we could target the exact place that we can actually find our diagnosis. And then I also say that we didn't do this ANA, SPEP, and UPEP because, first of all, we didn't really have a lot of history supporting SLE or even a Still's disease because of the nature of the arthritis, also the fact there was no rash, and then also the fact that we didn't get much in the other labs, like the renal function. And although yes, they could have presented late, but we decided to prioritize what could give us the most important diagnosis and what can actually also rule out other diagnoses. At this point, we have not yet even done the TB test from sputum because it was very difficult to induce. So we just did all with a biopsy. So with the biopsy, I have a picture here. We did biopsy of the lymph nodes, and then we did biopsy of the bone marrow. I know there's time, but just because of learning purposes, I'm sharing my screen to show. This is a picture I took from online. That will just give us the idea of what we saw in this case. So I have circled, I think we can just call it out and then I would continue quickly from there. What the pathologist.
I'm far away from his histopathology, so you circled this cell here. I don't know if anybody Reed Sternberg. I don't know. Owl eye.
Yeah, that is correct. So that's the owl eye appearance.
Okay.
That's it.
Kudos to Shreya had mentioned that. Oh,
Sorry.
Eugene.
So the pathology report, sorry. The pathology report came back and it had the phase architecture, nodules with sclerotic stroma, and then lacuna Hodgkin cells, Ristender cells, background of eosinophils, neutrophils, lymphocytes, and plasma cells. The gene expect on the tissue was negative, AFV was negative, culture was negative. Bone marrow biopsy also had hypercellular marrow with occasional Ristender cells, and then that was the evidence of the marrow infiltration. So we made a diagnosis of classic Hodgkin's lymphoma. It had to be staged. So we repeated most of the labs with echo, LFTs, renal function test, and we already had CT scan, chest X-rays. So we had an Abbott stage 4B, which is primarily because of the bone marrow involvement and then the extranodal involvement with the B symptoms. So we referred to oncology. Lucky for us, this was a case that, although it was that extensive, but they respond very well to treatment. So we saw this case back in July, and this child is doing well, but has one last cycle to go. And then I learned after that, we need to monitor them to, I think 3 months or 6 months to make sure, because within the first 2 years, they're able to relapse. And so what I learned from this case, it's more of the bigger umbrella of autoimmune, infiltrative process, chronic inflammatory process, chronic infections. Yet we tried to follow with the first thing that clued us in was the lymph nodes that were firm, they were solitary, and they were non-tender. So it began screaming malignancy to us right in the start. Unlike TB that usually may be matted, but not all the case, acute infection that may be tender. So we were more towards the malignant area with the lymph node, the palpable cervical and maxillary lymph nodes from the start. Then when the ferritin was not extremely raised, we took away some of the other differentials that could be found in this child, like the juvenile, the Still's disease, then also other, even, at a point, people were calling histoplasmosis and others, but we focused on things that were endemic in our environment because this child had not had any travel history and all of that. So that was how we were able to. Another thing that actually clued us in was the lytic vertebral lesion. We were able to, and we've seen Pott's disease most of the time. Usually it has an abscess around it, though it's also lytic, but this one was a clean lytic vertebral lesion. So we're able to get that picture that this could possibly be some form of lymphopoietic process over the TB. So that's where I would put my teaching points for this. Yeah.
Wow, amazing case, Eugene. Yeah, you had us spinning all over the place, but I think that was in the running. I think you're on to leukemia, lymphoma with lymph nodes. Definitely that was a consideration. LDH was high, and then cervical, right? Hodgkin's, younger people, cervical, supraclavicular, that distribution. Now it makes sense in retrospect. Mengyu, any reflections?
Wow, I'm so grateful for your case, Eugene. It's such a mind-blowing. I'm also so amazing. I'm also examining my illness script for Hodgkin's lymphoma. I think the continuous distribution spread of the lymphadenopathy makes sense. And now in retrospect, also, like understood why you gave us the info on the eosinophil count, because it does cause eosinophilia. And I guess I didn't realize it could cause this degree of leukocytosis. But now do see it's a common presentation of Hodgkin's lymphoma. So I think there's so much to learn from your case and such a rich differential diagnosis. So thank you so much. I have to spend more time reflecting on your case.
And we'll turn it over to Saket for teaching points. Take us home.
Yeah, thanks a lot for the amazing case, Eugene. I think you summarized most of the important teaching points. I'll just quickly try to summarize the case the best I can. So we started off with multiple joint pain, and it's always good to distinguish single versus multiple joint involvement and inflammatory versus non-inflammatory type of pain, because this distinction helps us separate localized causes like trauma or infection from more systemic processes like autoimmune or hematologic diseases. Next, we saw that this case had a lot of systemic clues, and the combination of joint pain plus systemic features like fever, weight loss, along with the hepatosplenomegaly and lymphadenopathy should trigger evaluation for chronic infections like TB or HIV, or diseases that lie on the autoimmune spectrum like Still's and lupus, and also malignancies like leukemias and lymphomas, which we were considering. Once we came to the labs and imaging, we saw that this patient had an elevated ESR, CRP, cytopenias, thrombocytosis, and high LDH, which all point towards a chronic inflammatory process, and possibly processes that could also have increased cell turnover. And imaging showed non-calcified nodules with lymphadenopathy, which further narrowed our differential to either granulomatous infections, possibly histiocytic disorders, or even hematologic malignancies. And as we saw, the final lymph node and the bone marrow biopsy showed that this patient had reached Sternberg cells, which was evocative of Hodgkin's lymphoma. Thank you so much for the case.
Wonderful job, Saket. It's very concise and to the point. So wonderful. Thank you very much. Thank you, Eugene, for the case, and thank you to Sam and Lyra for co-scribing together, and also wonderful job, Mengyu, for co-discussing. Absolutely had a blast. Please come back again. Take care, everybody. Have a wonderful rest of your Tuesday. See you tomorrow. Bye.
Bye. Thank you so much, all.